Module 2, Integumentary. This is your required readings. We'll be covering chapters 49 and chapter 50 from your Davis textbook. Major concepts, we're going to talk about integumentary function and skin disorders. We're going to start with a brief overview of the integumentary system function. So part of this system includes skin, hair, and nails. Skin's function is to protect us from injury. It helps to regulate our body temperature. It plays a role in vitamin D metabolism, sensation, and excretion. Our hair helps to reduce heat loss, and it also protects our skin from the sun. Then we have our nails, which are there to protect our fingers and toes. Assessing the integumentary system includes obtaining the patient's demographics, knowing the patient's comorbidities, so any other conditions or diseases they have, what medications they're taking, because there's a lot of medications that have side effects that affect the skin, family history, because many skin conditions run in families, and their nutrition status. As we know, our skin needs adequate nutrition in order to maintain integrity. So we want to make sure they're taking in enough protein and they're hydrated, etc. So some age-related changes related to the skin. So all of those basic functions that we just talked about on the previous slide, including protection, temperature regulation, vitamin D metabolism, sensation, excretion, all of those functions are less efficient. Okay, so as we get older, those for example, temperature regulation. If you are outside, you might get cold quicker. You need a sweater, where 20 years ago, your body maintained that warmth for you. Moving on, your skin becomes increasingly fragile. Wounds take longer to heal. So please review Table 49.15, Common Age-Related Skin Conditions. So there are some diagnostics that we can do related to our integumentary system. We can take a swab culture. That is one of our responsibilities. We can do needle aspirations. Well, not us, but the physician. Biopsies are also done on the skin. Our responsibility is to ensure the patient knows how to take care of that wound that a biopsy leaves. They should be keeping that wound clean and dry and changing that dressing daily. We're going to look at labs, CBC, albumin, lactate, BUN, creatinine, and blood cultures. This is to rule out infection, to assess nutritional status. We can see if the patient is anemic. And then we can also do Doppler ultrasounds to evaluate blood flow through vessels. Because if there isn't adequate blood flow, then the skin isn't going to get oxygen and other nutrients. It needs to, again, maintain skin integrity. And this picture here is showing Levine's technique in swabbing a wound. So this right here, let me circle it for you, is a swab we use to take a culture. So when you have a wound, you want to make sure that you're pressing this cotton tip in an area of the wound bed that is free of any debris, any slough, any exudate. You want to clean up 1 centimeter by 1 centimeter little square, push down on the wound bed with the swab to hopefully get some of that exudate from the wound bed. That would be the appropriate way to send a wound culture. Now let's talk about skin disorders. So first up is bacterial skin infections. So there are two main groups, non-necrotizing and necrotizing. So necrotizing spreads quickly and it destroys tissue, and it can be potentially life-threatening, especially in the older adult. So the way you're going to diagnose this, we can use one of those culture swabs. We can look at lab work. We can look at electrolytes and C-reactive protein. So when a C-reactive protein is elevated, that means there's some type of inflammatory response from the body. Biopsies can be performed, and we can also do nasal swabs. So although culture and sensitivity is listed along with biopsies, those aren't that commonly used. They're not as necessary for skin conditions. This is only when the condition isn't known based on the interview with the patient. Usually physicians, providers can figure out what the cause is without having to do a biopsy. but that is an option just to confirm a diagnosis maybe. So each type of bacteria has its own clinical manifestations, signs and symptoms, so it depends on which organism is involved. And the treatment for bacterial skin infections is going to be antibiotics, whether it's a topical ointment or it's going to be a systemic antibiotic like a PO, like a tablet that you swallow, or an IV injection. So if you have a superficial bacterial infection, then you're going to be given some type of topical antibiotic. And sometimes bacterial skin infections, they may not even need bacterial ointment. Sometimes they resolve on their own. They're self-limiting. So it just depends on the organism and a really good assessment. So we want to be careful with the overuse and misuse of systemic antibiotics because sometimes they're not necessary. If the infection is superficial, it's only in the epidermis, then there is no need for systemic antibiotics. When we give patients antibiotics when they don't need them, that's how we create these superbugs that become resistant to antibiotics. So that's why a good assessment, physical assessment, and interviewing the patient is so important. So you want to also teach the patient to do lots of hand washing, good hand hygiene, because bacterial skin infections that have drainage, any kind of exudate, debris, that is all infectious material and that can be contagious. So we want to make sure they're practicing good hand washing, that they're not sharing towels, and they're not sharing pillows or linen or clothes, anything that can transfer wherever that bacterial skin infection is. So here are some infections, skin infections. Okay, so we have cellulitis. I'm sure you all have heard of cellulitis. So this is inflammation of the dermis and the subcutaneous tissues. So this is not superficial. This is deep, deeper than the epidermis. So this will manifest with the 5 cardinal signs of inflammation: the pain, the edema, the warmth. It'll be painful, loss of function. When this progresses or it is more severe, then the patient can develop lymphadenitis. So that is swollen lymph nodes. And they may also have a fever. And then Staphylococcus aureus and Streptococci are usually the bacteria that is causing the cellulitis. So the cellulitis starts with some type of break in the skin. It could be just a little scratch, a little abrasion, but that impaired skin integrity is a portal of entry for the organism, and that's all it takes for the cellulitis to start. Now you might see a patient that has cellulitis, but there is no wound. It's just the skin is intact as far as you can see, so that is very common. But sometimes you'll have a patient with cellulitis, and then you also have to do wound care on an area which was the original portal of entry. Okay, then we have a furuncle. That's a boil. That's a deep infection with staphylococci around a hair follicle. So the difference between a furuncle and folliculitis is the depth that is involved. So furuncle is deep, folliculitis is superficial, and they both involve a hair follicle. So with furuncle, you're going to get a pus-filled lesion. It can be small, but they can also get really big. If they're small, the patient can manage them at home. They can apply warm compresses, and it could be self-resolving. Eventually, that lesion will develop a yellow-white tip, and then it will rupture and drain. But if the furuncle is very big, then it may need to be drained by the provider in the doctor's office. And then for folliculitis, again, that's superficial inflammation and infection of a hair follicle. It can be, like this picture shows, multiple or single little pustules with a hair follicle in the center. That can be painful. We do the same thing. We want to provide warm compress for natural drainage. If any of these, because this is bacteria, if they get really big and they require incision and drainage, they may also need to be packed, like as part of wound care, and they may need antibiotics. And again, only skin conditions that are below the epidermis will need systemic antibiotics. And then our fourth one here is impetigo. So this is bacteria in the epidermis. It's localized, so it kind of stays in one section. And this is very contagious. So it's common in kids, and when one gets it, it's kind of passed around pretty quickly. So these patients have little vesicles, which are little fluid-filled pockets, and it's referred to as honey-crusted sores. So if you look at this picture, it kind of looks like you had honey that kind of dried up. Please review Table 50.1 on uncomplicated skin and soft tissue infections. Next is herpes simplex virus. So HSV, there are two strains, HSV1 and HSV2. You can get both strains or just one. This is a lifelong incurable infection. So these patients will forever have this virus in their body. It is very common. The HSV1 virus is more associated with above the waist, so like in the mouth, and HSV2 is more associated with the genitals or below the waist. They can be reversed, it's just more common in those areas. So these viruses can be transmitted asymptomatically, meaning the person who's carrying it has no symptoms. This can be through body fluids, skin-to-skin contact, skin to mucosa contact, or mucosa to mucosa. The HSV1 can be transmitted without sexual contact, and oral labial lesions, so like around the lips, can actually occur at a young age, and that is most likely because when you're kids, you might share utensils or cups, during childhood, and it can just be passed that way. So pathophys on herpes simplex virus. So the primary infection occurs with direct contact with an individual with HSV. That's the very first time they get infected. So then now the virus is in them, it's never going to go away. So the second time, or for, thereafter, every time they get an infection, it's going to occur following an exogenous or endogenous trigger. So that means something is going to trigger either from the inside the body or from the environment. That's going to reactivate the dormant virus, and then that's when you see these lesions emerge. So there's periods of remission and then periods of exacerbation. So some common triggers would be UV light exposure or sunburn, a febrile illness, stress, and menses. So for example, somebody who has herpes simplex virus, maybe they go to the beach, they had no lesions present, but they do have the virus. They're out in the sun, they get a sunburn. A couple days later, they're going to start to have a flare-up of vesicles and infection. So HSV is often symptomatic unless there is an active exacerbation. But if there are signs and symptoms, it would be fever, malaise, myalgia, which is muscle pain, anorexia, irritability, lymphadenopathy, which is swollen lymph nodes, and lesions on the lip, face, and mucous membranes. Again, it could be asymptomatic. So the way this is going to be diagnosed is we're going to do a history and physical, and to see what it looks like, what the clinical presentation is. There is virological testing, so we can take a blood sample, send it to the lab, and then also serological type specific glycoprotein. So this is to really hone in on which HSV virus is it, or another classification of a different virus. So the way we're going to do our assessment, we're going to check vital signs for pain and fever. We're going to inspect the mouth and genital areas. We're going to find out about their sexual history. We want to know how they got it. Are they active right now? We want to test for pregnancy. We want to make sure that if this is a female patient that's pregnant, that they don't have any active lesions when it's time to give birth, because they will need a C-section. And then one of the most significant complications of HSV infections is the effect on quality of life because of the psychosocial stress of this diagnosis. So some patients report feeling isolated, devastated, and embarrassed because of the diagnosis. And there's a lot of fear of transmitting the virus to somebody else. So teaching, we want to teach them about the medications that they may be prescribed, antiviral meds. We want to teach safe sex practices and let them know that the greatest risk for transmitting the infection is when there's active lesions present. This just means the greatest risk. It's not the only time. Even if they're asymptomatic and they don't have any active lesions, they can still transmit the virus. And then we want them to follow up with their provider. Next are fungal infections. So fungal infections are spread directly from person to person or through animal contact or indirectly through an inanimate object that has that holds skin scales from infected hosts. So let's talk about dermatophytes. So dermatophytes are anaerobic fungi that infect the stratum corneum. So this is a layer of the skin. It's the very top dead layer, actually, of the skin. And these dermatophytes survive on keratin. So they don't really live on mucosal surfaces because they eat that keratin from our dead skin. And they reproduce by spores, and they live on the epidermis, which is that top layer of the skin. So the diagnosis of fungal infections are usually made with a focused history, a physical exam, and a KOH, which is a potassium hydroxide test. Also, a fungal culture can be done, or a histological tissue eval. That's where they take a sample of tissue and look at it under the microscope just to confirm diagnosis. So for treatment, we're going to give antifungals. And fungal infections can show as rashes, plaque formation, pustules, vesicles. A lot of times, these fungal infections, you'll see it in the abdominal folds, or under the breast, or in the axilla. We also see fungal infections on the tongue as thrush or candida. So these opportunistic organisms often show up when the immune system is compromised or when patients are taking a lot of antibiotics. It gives these organisms an opportunity to grow. So we want to make sure that these patients wash their hands, and they take their medications, and we clean incontinent patients as soon as we know that they're wet. And those skin folds, we want to keep them dry. There's a lot of products that we can use to place in between. And then we don't want the patient to wear tight fitting clothes. We want to make sure they know what the signs and symptoms are of fungal infections and to report it to their provider, and to complete those antifungal infection medications as prescribed. And critically ill patients and patients who have a compromised immune system, they are at risk of having a blood infection with fungus, and that is really bad. If you get fungus in your blood, it has a high mortality, so high risk for dying. Moving on to psoriasis. Psoriasis is an autoimmune disorder that causes chronic inflammation of the skin, and we characterize it by a thick, raised areas of red patches that are covered in silvery flaking scales like you see here in the pictures. And because it's an immune disorder, it also has periods of flare-ups or exacerbations and remissions. So the skin kind of calms down, and then you have these periods where the patient is triggered. It could be an infection, medication, stress, trauma, hormones. Those are all things that could aggravate the disease and cause these flare-ups. It is unknown why psoriasis happens. So psoriasis is actually the production of new epithelial cells just really, really fast. So it results in more skin cells that are made than are actually shed. So this excessive production of cells leads to these scaly plaques on the surface of the skin. All right, so signs and symptoms, we talked about it. Thick raised red patches, silvery flaking scales. These areas of plaques are often seen on the elbows, knees, legs, palms, soles of the feet, scalp, trunk, and face. So there aren't any specific lab tests to diagnose psoriasis, it's most based on history and the clinical manifestations, what their skin looks like. So treatment-wise, we want to reduce those scales and those patches on the skin. So these patients will be prescribed topical creams. Most commonly is going to be corticosteroids. And we want to be careful with those because that can actually cause a thinning of the skin, atrophy of skin cells. Some of the topical medications can stain the skin, hair, and nails and clothes. So we want to make sure the patients are aware of that. And retinoids can cause skin irritation, and let's see, systemic toxicity can occur if used in conjunction with oral salicylates. So the takeaway here is that you want to get a good patient history, know what medications are already on, so you can see if any of the medications you're going to be prescribing are going to cause some kind of contraindication. UV light therapy for psoriasis. So side effects of this phototherapy would be itching, burning, redness, stinging, and also puts them at a greater risk for skin cancer. Can cause abdominal fullness and flu-like symptoms, including nasal congestion. There are also some systemic medications that they can take by mouth or by injection, such as methotrexate, cyclosporine. And these have lots of side effects. They can lead to infection, fever, nausea, infertility, photosensitivity, liver and renal damage, hair loss. So these all come with side effects, and it's really important that your patient understands this. And we want to provide emotional support because these plaques, sometimes they can't be hidden. Sometimes they're on the face, they're obvious, they're on the hands, and these patients can experience low self-esteem and altered sense of body image because of the plaques. So we want to refer them to psychosocial counseling because psoriasis can have a negative impact on quality of life. So we want to make sure that we are taking care of them in that area. So some other complications, this psoriasis puts them at risk for other diseases like cancer, cardiovascular disease, Crohn's disease, metabolic syndrome, liver disease, and of course depression and anxiety. So we want to make sure these patients are given the medications as ordered. We want to monitor for side effects and make sure these patients follow up to see if the plan of care is effective. Moving on to skin trauma. So skin trauma can either be a laceration, an abrasion, excoriation, friction blisters, and skin tears. That about covers it all. So there's an example of each one in this picture. 4 phases of wound healing. It starts with hemostasis. That's when the body makes a fibrin clot. Then we have the inflammatory phase. That's where our immune system, comes and looks to see what happened, tries to clean up the area for healing. We have the proliferation stage. That's when there actually tissue building starts to happen. And then we have the maturation where scar tissue is formed. Types of wound closure. So we have ABC, primary intention, secondary intention, and tertiary intention. So primary intention is here on the first row. That is when the wound edges can be approximated. That means that they come together very nicely without having too much tension, and the provider is able to suture, staple, or glue that incision shut, and it closes very nice and tight. Then we have secondary intention. This is where there's too much tissue loss to bring those wounds together. They will not approximate. So instead, the wound is left open to heal, and it heals from the inside out. This will leave a much wider scar than primary intention. Primary intention will usually have like a nice fine scar, where secondary intention is going to have a thicker, wider scar. Then we have tertiary intention. So this is when the wound is intentionally left open and the closure is delayed because the wound is contaminated, it is infected. So one thing to remember is that contaminated wounds, infected wounds will not heal with infection. So that infection needs to be cleaned out, debrided, wound care, antibiotics, whatever is causing it, before that wound will heal. And then after all of that infection is clear, then the provider can decide whether they want to leave it open or they want to close it up. This is an example of primary intention. These are sutures, nice and straight. This scar should be very fine, very small, thin scar. This is secondary intention. This actually looks like a punch skin biopsy. So there isn't enough tissue here to bring these edges together to approximate without there being too much tension. So this was left open, and you can see here, you can barely see the scar. This is tertiary intention. So this is a wound that we're unable to close it because it's just too much infection there. So once that is cleaned out and left open, that will heal from the inside out. It will leave a bigger scar. So for skin trauma, so we want to make sure the patient has adequate nutrition because we need nutrition to keep our skin nice and strong. We want to assess the peripheral vascular status because we need circulation, we need nutrients to, fix our skin. Interventions. So we want to perform wound care as prescribed. Remember, all wound care is a doctor's order. We can give medication before we do wound care. We should give it at least 30 minutes before. We're going to give antibiotics. We're going to refer the patient to a nutritionist if needed. And if they have issues with circulation, we're going to refer them to, a vascular consult. We want to, again, this is generalized skin trauma. So if the patient is incontinent, we want to keep them clean and dry. And the way we're going to know if everything's working is if we have wound healing. Next is pressure injuries. So pressure injuries occur due to unrelieved pressure. So if you push down on your skin for long enough, you're going to have lack of circulation. So your skin cells are going to be starving and they'll die, essentially. So this is most common on bony prominences. Medical devices, we include friction and shear, and excessive moisture will increase the risk for skin breakdown. So patients that are incontinent are higher risk and can develop pressure injuries in those areas much quicker. So here are the main pressure points that you want to keep in mind if the patient's on their back, on their side, if they're wheelchair bound, and if they have some type of medical device. A lot of pressure points. This is a picture of pressure injuries that we don't always think about. So remember, whenever there's any type of tube being used, it can be oxygen, it could be a drain, it can be like a drain after surgery, a JP drain, it can be a Foley catheter. Any type of foreign object that sits on the patient, there's a potential for skin breakdown. So that's why you as the nurse every shift needs to do a really good head to toe, especially when patients have these tubes. So this one is on the top left is a feeding tube. You can see on the left here, I'm circling it. That is a pressure injury. Here on this patient, this is from a BiPAP mask. Again, this is preventable. Here is from a nasal cannula. This is under the trach plate, tracheostomy plate. And then here, this Foley catheter port got stuck in between the abdominal folds and broke the skin. So this costs hospitals, facilities a lot of money. And not only that, but it increases the length of stay at hospitals and it can potentially lead to death. So when this happens in the hospital, we call that a HAPI. It is a hospital-acquired pressure injury. So we try to avoid this at all costs. This affects millions of people a year. There's a lot of lawsuits and there's a lot of people who die from this. So we need to do our best to prevent them. For any hospital or facility that has a patient that has a stage 3 or 4 pressure injury, stage 3 or 4 pressure injury, hospitals have to report that to Medicare and Medicaid services. So that would mean that they may not get reimbursed for the care of these pressure injuries. So this is a picture of friction and shear. This is really common when you sit the patient up in high Fowlers and they just slide down the bed. So one way to avoid that is not sit them so high and or to bend the knees of the bed to kind of prop them up. So when the body slides down, the skin goes down, there's friction, but the subcutaneous tissue doesn't go down, it goes up. So that creates these little micro tears that decreases perfusion to those areas and can cause injury. So the risk factors for pressure injuries: if the patient has decreased mobility, if they're older in age, if they have other comorbid conditions like diabetes, the use of steroids, if they have any kind of condition that affects blood flow or the presence of oxygen, like being anemic. Cognitive impairment, maybe they don't know to reposition themselves or remember to reposition themselves. If they're incontinent, if they're malnutrition, if they're dehydrated. If they already have a history of pressure injuries, then it puts them at greater risk. And a terminal illness also, because like we talked about, terminal illness, all your body organs are failing, including your skin. So one thing, this picture here, or this little graphic, a patient is having surgery. So if you are a healthy person, maybe you're in your 20s and your 30s and you're having surgery. So that puts you at risk for a pressure injury, because when you have surgery, you go in, you lie on your back, and if you remember that other picture, all of those bony prominences are being exposed to your weight. So just because you're a healthy person, it doesn't mean that you don't have any risk of getting pressure injury. So usually what they'll do if the surgery is going to be several hours long, they'll put foam pads on the bony prominences before surgery starts just to protect those areas. So now we're going into the pressure injury stages, and the stages are based on depth. This is stage 1. Skin is still intact, but it does not blanch. So when skin does not blanch, meaning you see this redness here, if you press down with your finger on a normal healthy skin, it should turn white. And then when you release your finger, it fills up with color again. But when you do that to a stage 1, it does not blanch. It doesn't turn white, it stays red. So what that means to you physiologically means that there is lack of blood flow, lack of circulation. Stage 2, skin is not intact. There's partial loss of dermis. So if you see in this picture, the epidermis is completely affected and partial loss of dermis. This also includes an open or a closed blister. So even if the blister has not ruptured, we still consider that a stage 2 if it's over a bony prominence. Then we have stage 3, skin is not intact. So this is full loss of skin tissue. So now we're into the subcutaneous fatty tissue, which is yellow. Okay, so not superficial. This is full loss of skin tissue. And sometimes the wound edges may roll away from the wound bed, and you can kind of see that a little bit in this picture. Stage 4, this is the deepest of the pressure injuries. This is where you're going to see bone, tendon, muscle, ligaments, like this picture. Then we have unstageable. So if you see an unstageable wound, you'll either see it like a black crust, like a leathery crust, or this eschar here with slough. So we cannot see the wound bed, so we're not able to stage it. Even if you look at this wound and it's very obvious that it's not a stage 1, not a stage 2, probably not a stage 3, this is probably a stage 4. It doesn't matter because we can't see the wound bed. So all of this material here, all of this debris, it needs to be taken off. It needs to be debrided. Once all of that necrotic material is off and we can see the wound bed, then it will change from unstageable to whatever stage it is. Next is deep tissue pressure injury, or DTPI. So this is intact skin. Okay, so there's no open skin here. And this looks purplish, dark maroon color, discoloration in the skin. So this happens when fatty tissue or subcutaneous tissue is injured beneath the skin, and it may feel spongy or boggy. So this deep tissue pressure injury is very, very high risk for opening up and turning into a stage 3 or 4. So we want to be really careful and try to prevent that from happening if the patient has DTPI. This is tunneling and undermining. So tunneling is just like the word says, it's a tunnel. So there's little tunnels inside, and you can see this picture here. They call them sinus tracts. So when we are assessing the wound, we need to measure those tunnels. So you'll get a long cotton-tipped applicator, and you're going to insert it into each sinus tract or tunnel, and you're going to mark how deep it goes in. And then when you document it, you're going to use the clock. And for example, this picture under tunneling, that kind of looks like it's at 9 o'clock. You're going to say 9 o'clock tunneling, 4 centimeters. And you're going to go around the whole wound and document it that way. Those type of wounds are usually packed with packing for the wound care. Then we have undermining, which is on the right. So undermining, you can see here in this drawing, is that it refers to right beneath the skin. So it's not a tunnel that can go anywhere. This one is right under that top skin layer. When we do our assessment on wounds that have undermining, we are going to insert that cotton tip applicator, and we're kind of going to pull it. We're kind of going to pull it up. And then wherever we see that protruding through the skin, we're going to measure. We're going to draw. And that drawing is actually how we're going to measure that wound. So this is a practice question. You have an 86-year-old female who is immobile and is in the right lateral recumbent position. Which sites are most at risk for pressure injury? So you can take a look at this, pause it, and then let's look at the answer. So here you go, all of these: ankle, ear, hip, knee, and shoulder for an immobile patient in that position. So how do you know when a pressure injury is infected? Because just because you have a pressure injury does not mean it's infected. So you're going to have leukocytosis, which is elevated white blood cell count. You're going to have fever, and the wound is going to increase in size, odor, and drainage. You may see some necrotic tissue there. It can be slough or eschar, that black leathery look to it. It can be indurated, warm, and painful. Some complications from pressure injuries: it can lead to cellulitis, it can lead to chronic infection, osteomyelitis, which is infection in the bone, and it can lead to death. But the most common complication is reoccurrence. Okay, so I'm going to go over just a few things about wound care. So when you perform wound care, we're going to follow prescribed orders, because all wound care needs to be prescribed by a provider. It could be the doctor, it can be an NP, it can be a wound care specialist, but it's a prescription, it's a doctor's order. So we want to pre-medicate a patient 30 minutes before, if applicable. So if it is a wound that the patient is alert, oriented, they have sensation, it's painful, then we're not going to make them suffer. You want to think ahead and anticipate, pre-medicate them so that they can be more comfortable. When you irrigate a wound, so when you're using some type of solution to clean it out, you want to avoid cytotoxic solutions. So what that means is these solutions that we use shouldn't be killing normal healthy cells. An example of that would be hydrogen peroxide. So when you pour hydrogen peroxide on a wound, it is cleaning it, it's debriding it, but it's also killing good healthy cells. So we don't want that. So we want to avoid cytotoxic solutions. We can use sterile water, we can use normal saline. There's a thing called mechanical debridement, and that is the purpose of wet to dry dressing. Just keep in mind that the term wet to dry dressing, it's something old that's not done so much now. And I'm going to describe it to you. So when you do wet to dry dressing, you have an open wound. You get some 4x4 gauze, you open up that gauze and fluff it out. You dip it in some normal saline, you squeeze out the excess, and then you pack it into the wound, gentle packing. Once the wound is gently packed, then you're going to cover it with a dry dressing, another 4x4, and then you're going to put an abdominal pad, tape it up. That is your wet to dry dressing. So why is this considered mechanical debridement? So when it's time to change that dressing, you're going to remove that abdominal pad, remove the dry 4x4, and then you have to remove the packing that you put in it. Well, now it's no longer wet because as it dried, it's kind of sticking to everything that was in the wound. So when you pull it out, it's bringing all of that with it. So again, it's going to bring out all that gook and stuff we're trying to get out, but it's also going to be pulling at healthy cells in there, which is not good because we want to keep those healthy skin cells. Then we also have chemical debridement. This is when we actually use an ointment. You'll most commonly see Santil. There isn't a generic version of this, so you'll see collagenase. That is the generic name, but that's the only chemical debridement that they have. It's very expensive, so a lot of hospitals may not carry that. Instead, they'll have Medi-Honey, which you can buy over the counter. And it just debrides it. It removes that necrotic material so the wound can heal. Doctors can also use silver nitrate sticks to kind of burn off that gooky stuff too. Then we have surgical debridement. This can be done at the bedside or in the operating room. The patient can be sedated. It really just depends on the wound, how deep it is, how severe, how invasive they need to be to remove all of that necrotic material. You can see in this picture, this is a surgical debridement. They're cutting it off. And then here in this picture, 1, 2, 3, this is a chemical debridement. So the first picture shows before treatment, and then after many, many wound care changes with the ointment, eventually it becomes nice and clean wound. This wound on the right will heal. So chemical debridement takes a while, but it's very, it's not very invasive. So patients that may not be a candidate for surgical debridement can have a chemical debridement and it still works. It just takes longer. Then we have a wound vac. So a wound vac is pictured here on the right. And this is for wounds that need a little bit of extra help to kind of get that exudate out and to kind of help bring blood flow to that area. This is hooked up to a suction machine that is has a gentle suction. And that's something that you would monitor throughout your shift, and it's part of the patient's output. Hyperbaric therapy. So this is a chamber that provides high levels of atmospheric oxygen. This is very, very beneficial when it comes to wound healing, but this chamber isn't always accessible to patients. Only some hospitals have it. It's expensive. So if the patient doesn't have access, they don't benefit from that. Nursing management of pressure injuries. So when you have a patient, whether they have a skin problem or not, we're going to do a head-to-toe skin assessment on every new patient and on every shift. So you're going to document the stage, the location, the size, the color, the drainage, and if it has odor. You're going to take pictures per your facility's protocol. Usually it's weekly. And if you do have a new patient that comes in with a really big pressure injury, you want to let the physician know to see if they want to get a culture or maybe a wound care consult. So every shift, we also want to assess the patient's risk for pressure injury with some type of standardized tool like the Braden scale, which you're all familiar with. So we really want to focus on those pressure-prone areas, so any kind of tubes that they have, and then all of those bony prominences and medical devices. We want to make sure they're getting adequate nutrition. We want to know about their past history, and we want to check their labs for those essential albumin and pre-albumin levels, which will give us insight on their nutritional status. So some more interventions for pressure injuries. The number one is repositioning. This is in the hospital and also teaching the family members and the patient of how important it is to reposition the patient every 2 hours. We want to keep the head of the bed lower than, we want to keep it in semi-Fowlers. When the patient is sitting upright, that puts a lot of pressure on their coccyx. We want to utilize draw sheets so they don't experience that friction and shear. We want to use the products that our facilities have when it comes to incontinence care, like moisture barrier creams. Some hospitals have special surfaces that they have for patients who are high risk for pressure injuries, like special air mattresses. We want to make sure we're providing accurate documentation, getting a nutrition consult on board if necessary, giving medications if necessary. And we also want the patient to know once they're discharged to make sure that they know the signs and symptoms of infection. This is the Braden scale for your reference, and you should all be familiar. All right, moving on to skin cancer. This is our last topic here. All right, so the number one enemy to our skin is the sun. So these UV rays, these ultraviolet rays, can cause damage to our skin. It can cause premature aging, and it can burn our skin. So we want to educate patients to wear protective clothing like a big hat, long sleeves, glasses, and to wear sunscreens. So if you're at average risk, you should be wearing at least 15 SPF, which is sun protection factor, and 30 SPF or higher if you're high risk. And then it should be broad spectrum so that it covers all of the different types of UV lights. Skin cancer risk factors. Genetics plays a huge role. If you're fair skin, blonde or red hair, blue eyes, you're higher risk for skin cancer. If you spend a lot of times outdoors, maybe recreationally, like at the beach, sunbathing, or if you work outside. If you live near the equator, if you get frequent sunburns, and if you're on any type of medication that suppresses your immune system, it's going to put you at higher risk for skin cancer. So taking a deeper look here at the layers of the skin. So the 3 different types of skin cancer, they're named after the cells that they mutate from. So squamous cells mutate into squamous cell carcinoma, basal cells mutate into basal cell carcinoma, and melanocytes mutate into melanoma. So skin cancer is staged by the depth. So the deeper the skin cancer, the poorer prognosis. Actinic keratosis, so this is precancerous, and it can develop into squamous cell carcinoma if not removed. So if you have an older patient, you want to make sure you check the areas of their body where the sun hits, so like the head, the neck, the face, the arms, the hands, the legs. And if you see this scaly reddened patches like you see in this picture, it could potentially be this precancerous skin condition. So if they do have this, we want to remove it. Okay, so we don't want to take the risk of them getting skin cancer. These next few slides, I'm not going to go into detail. This is for your reference only since your textbook doesn't go into depth about this. So basal cell carcinoma, most common type of skin cancer. It's the least deadly. Metastasis is rare. So whenever you hear that a cancer is least deadly, it just means it's slow growing. That's all it means. So it's going to have a pearly, waxy, glossy look to it with a depressed center and raised edges. Then we have a squamous cell carcinoma. This is the second most common skin cancer. With this one, metastasis can occur or spreading. It looks crusty, scaly, hard, and it's raised. Okay. And the treatment for these include excision, electrodesiccation and curettage, Mohs surgery, lymph node surgery if it's spread, and grafting and reconstruction if it's severe. We can do radiation and cryotherapy. It really just depends on the patient. One thing you need to be concerned about as the RN is the aftercare if they do these procedures. So there will be an open wound, so we want to make sure they look out for signs and symptoms of infection. And also they'll need to change the wound dressing at home. Normally it's keeping it clean and dry, keeping the wound bed moist, and changing the dressing daily. Malignant melanoma, this is the highest risk of metastasis. It is fast growing, and this is where we want to pay attention to the ABCDE in appearance. So if you see this lesion here on somebody's body, you can see that it is not symmetrical. So that means if you cut it in half, both sides don't match. The borders are uneven. That is very obvious. You can see it's kind of wiggly all the way around. The color is dark, or there's multiple colors in the lesion. You can see there's a dark area here, light, a little darker and darker. And then evolving shape. So the patient may say, this lesion looked different a year ago. Now it's bigger and it changed color. So all of those are red flags that point towards a suspicious lesion. This is an atypical dysplastic nevus. It kind of shares the same ABCDE characteristics of melanoma, but they're less pronounced. And these are benign, so they're not cancerous. This is a nice picture. You should be very familiar with this because in your career you will look at a lot of skin, and then it can help you determine whether your patient may have skin cancer. So I'm going to click on through these benign or suspicious. Okay. So the risk factors for melanoma are the same as any other skin cancer. Genetically, if you have fair skin, blonde hair, if you have skin that freckles easily, a lot of outdoor sunbathing, all of that, same thing as regular skin cancer. The way this is diagnosed, so a dermatologist will have a dermoscopy. This is this little tool here where they can magnify and kind of look underneath the layers of the skin. And this is what they see here on the right. It's pretty interesting. So if they determine that it sees tissue that is suspicious, then they will do a biopsy of that. So when they do a biopsy, they're going to do an incisional biopsy here shown in the first one. And they're going to assess the tumor thickness. So we have the Breslow measurement, which is the depth of tumor in millimeters, and the Clark level, which is a number 1 through 5. The higher the number, the deeper the melanoma. So this is cancer. We talked about cancer in Module 1. So the treatment is determined by how severe it is. So has it spread? What is the stage? How deep in the skin it is? It always, though, is going to include a wide surgical incision and adjuvant therapy. What that means is if it's determined that this is melanoma, they're going to do a very large, wide surgical excision to remove it, and then the patient will be on some type of anti-neoplastic medication after that, chemotherapy. And just to recap, this is our last slide here. We want to do health promotion so patients don't get skin cancer in the first place. We want to, have these preventive measures and teach our patients to routinely check their skin from head to toe, have their partner look at their skin. Sometimes these lesions can be hiding, in the middle of their back. They can't even see it. We can teach the patient to use the ABCDE method to identify those suspicious lesions. We want to make sure that they know they should be wearing sunscreen, they should be wearing long sleeve shirts if they're out in the sun, a big hat, sunglasses, and they shouldn't be going out into direct sunlight when the sun is highest in the sky, which is between 10 and 4 p.m. So they should avoid that. And that concludes this module.